Live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar, Heart Diseases Complicating Pregnancy, organized by Pinnacle NEWS Series, and today's episode is 20. And this series is in association with Bidar, Bilaspur, Bilai, Narmadapuram, Radlam, and Mandya OBGYN societies. So let us start the webinar.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणि विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा।
It's my privilege to introduce the moderator of today's webinar, Dr. Madhumita Arun Karthik ma'am. Ma'am is the consultant obstetrician from Salem and secretary of Salem chapter of ISAR. I welcome you, ma'am.
Thank you so much, Sahiti. And I would like to introduce my co-moderator, Dr. Radhika Gauri, who's a consultant obstetrician gynecologist in Tirunelveli. Yeah. Next slide, please. Yeah. So I welcome you one and all to this very informative webinar on heart disease complicating pregnancy. This is organized by Professor Dr. Sampath Kumari, who is a professor and HOD of Muthukumaran Medical College and Hospital at Chennai, past vice president of FOXY, Senate member of TN Dr. MGR Medical University, national corresponding editor of Jogi, and also founder secretary of Tamil Nadu Federation of Obstetrics and Gynecology, and current president of Obstetricians and Gynecologists of South India. And ma'am was also the past chairperson of Foxy Adolescent Health Committee, and she received the first ICOG Distinguished General Council Member Award. And also she's the current chairperson of Women's Wing IMA Chennai South, and she's also received the IMA National President's Award and IMA State Award. Over to you for the welcome address, ma'am.
Yes, thank you, Dr. Madhumita. This Pinnacle series, this is Pinnacle News. We select societies from North, East, West, and South. And I welcome you all for this academic webinar. And I welcome the Bidar Society President Deshmukh and Secretary Dr. Savita, and Bilaspur Society President Dr. Chaudhary and Secretary Dr. Varsha, and Bilai Society President Dr. President and Secretary Dr. Anchana, and Narmadapuram Society President Dr. Ravindran and Dr. Sheetal Secretary, Ratlam Society President Dr. Sunita and Aditi the Secretary, and our Mandya Society from South, the President Dr. Manohar and Secretary Dr. Sweta. So our aim is to collect all North, East, West, South to combine together and participate and enjoy the webinar. Now today's our unique topic is heart disease complicating pregnancy. We have Dr. Sunita Samuel, who will be talking about the peripartum cardiomyopathy, and the panel with the case scenarios of MSMR and VSD by the moderator being the Bhumika. And we have the panelist Priya Kannapan, Radhika Gauri, Swati, and Dr. Rekha, Dr. Neha, and we have Dr. Dolly Mera and Dr. Monica. I think all of you will get important messages, take-home messages from this webinar. Once again, I welcome you all for this webinar. And now I am on way to Delhi. I am contesting for Foxy President, so I am traveling all the way today. I am going to Delhi. And now I welcome Dr. Manohar, the president of our Mandya Society, to wish our webinar. Dr. Manohar. Dr. Manohar is the president of the Mandya OBGYN Society. Dr. Manohar, are you there?
Yes, ma'am. First of all, I would like to thank our madam for giving an opportunity to be a part of this webinar. On behalf of the Mandya OBG Society, I would like to welcome all the panelists and also the moderator, because we are seeing a lot of RDCs in pregnancies nowadays. And hopefully this webinar is going to be more useful for all our consultants, and wish all the best for all the moderators and the panelists regarding the heart disease in pregnancy, ma'am. Thank you, ma'am.
Thank you, Dr. Manohar. Now I welcome our Dr. Sunita, the Rathalam Society President, Dr. Aditi, for to bless the wishing. Dr. Sunita is not there?
She's just
Yes,
joining,
Doctor.
ma'am. I just sent her the faculty link. She
Yes,
missed the
Dr. Aditi,
Aditi
on
is-
behalf of your society.
Thank you, ma'am. Good evening, ma'am. Good evening to all.
Welcome, Aditi. So, your president will be joining. Now we will start with the scientific session. Since we don't have if the other presidents and secretaries joining, we can involve them. Madhumita, can you see anyone? Dr. Varsha?
I mean,
No,
I'll
as on,
have to rename, I
as
think.
on, okay, as on Jan, if any president there, Bilar, Bidar, Bilaspur,
You have to rename, I think.
yes, let them, dear faculties and delegates, please rename it such that we can also have a group photo. Now we will go with the
Hello.
scientific session. Dr. Madhumita,
Hello.
you can introduce
Yes,
Hello,
ma'am.
I am Dr. Uma Deshmukh, President Bidar.
Yes, madam. Welcome, madam. Dr. Madam. Do you have the CV, Ma Bidar Society President?
Yes.
Dr. Uma Deshmukh. She is the HOD and of this OBG department, and she is the president of Bidar Society. Madam, we welcome you for the wishes for this webinar. Dr. Uma, welcome. Yes, madam.
I think ma'am has
You
got
can tell
disconnected.
few words. Yes, madam.
Ma'am is here.
Hello.
Yes, ma'am. We're able to hear you, ma'am.
Yes, I am
Sunita,
Dr.
ma'am.
Uma Deshmukh
Yes, ma'am. Welcome.
from Bidar. Actually, one more
Yes,
meeting is there at 5 o'clock from Government of Karnataka.
Okay, ma'am.
Okay.
Okay, ma'am.
Okay, madam. Thank you for joining us. And
Dr.
blessing
Sunita
this
has
webinar.
joined, ma'am. Dr. Sunita Wadhwani, Rathalam President, has joined, ma'am.
Dr. Sunita,
Welcome,
we
ma'am.
would like to tell you a few words. Welcome,
You're-
Dr. Sunita,
You're
Rathalam
muted,
President.
ma'am. You're muted, ma'am. Yes, ma'am. Yes. Welcome, ma'am.
Few words, Madam Dr. Sunita, Rathalam President. Thank you
good
for
evening,
joining
ma'am.
us in this.
I wholeheartedly thank you for getting us all together on this dais for this beautiful webinar. And with beautiful topics you have introduced to us, MP societies. For the upcoming elections, we would like to share our best wishes to you, ma'am.
Thank you, Dr. Sunita. Thank you. Please spread the message to your society.
We'll do that,
Thank you
ma'am.
for the
We'll
wishes and
definitely
thank
do
you.
that.
Sure. Thank you, Madam.
Ji,
Yes.
ma'am.
All
Now
the
we
best
will go
from
with the.
Bidar Society also, madam.
Yes,
all the
Madam Dr. Uma. Thank you. I'll try to come to all the places in person.
Yeah, we'll be more than
Yes,
happy to welcome you, ma'am.
Sure, Madam. I'll be coming, definitely.
Ji, ma'am.
Thank you all for the wishes. And now we will go with the scientific session.
Yes.
Dr. Madhumita.
Yes, ma'am. So moving on to
You can-
the scientific session, it's my pleasure to introduce a chairperson for the first session, Dr. Sunita Wadhwani, who's the president of Rathalam Obstetric and Gynecological Society. She's also the director and consultant at Rathalam Hospital and Research Center, NABH assessor, and she's done her MBA in Hospital and Healthcare. Her special interests are critical care obstetrics, and she's also the lead assessor and master trainer in Manyata by Foxy. Welcome, ma'am.
Thank you.
Can you
Thank you very
introduce
much,
yes, ma'am.
Madhumita.
Ma'am, thank you, ma'am. Yes, ma'am.
Ma'am, can we
Shakti,
introduce Dr. Sunita Samal?
Yes, ma'am. Sarthi, can we have Sunita ma'am's slide? Sunita Samal ma'am's slide?
Both
Yes.
are Sunita. Okay.
Yeah,
Yes.
Sunita, introducing Sunita.
Yes, Madam.
Yeah.
Sunita Square.
Yeah, ma'am. It is my privilege to be a part of this wonderful Pinnacle workshop. And it is again a privilege to introduce Dr. Sunita Samal. Ma'am is MD, FICOG, FMS, AS and ACME, consultant obstetrician and gynecology, laparoscopic and robotic surgeon, Apollo Women's Hospital, Chennai. She has done her UG and PG teaching DNB faculty. Special interest is minimally invasive gynecological surgeries, high risk obstetrics, basic fertility and medical education, 54 publication in various national and international journals. She has various awards to her credit. Best Poster Award, which was awarded to her in 2015 and 17. First in Foxy Zonal Quiz 2002. Dr. Anjala Chandrasekhar Award for Best Research Paper. International Scientist Award on Science and Medicine, organized CME and workshop, presented paper and faculty in various national and international conferences. She's the member of FOXI, OGSSI, IAGE, AMASI, ISOP. I welcome Dr. Sunita, and she would be talking on cardiomyopathy.
Thank you, madam, for the kind introduction. At the outset, I would like to thank Sampath madam for this opportunity, and also I wishes all the best. Like we wish she will be the next Foxy president. Yes, madam. Yeah. So I just share my slide. So first just start with the case scenario. So this is a 29-year-old like a primary para. She has just had a normal vaginal delivery without any problems, and she doesn't have any comorbid factor, no risk factor, nothing. And she was admitted in emergency with like some dyspnea and chest pain. And her BP was normal, pulse is also mild tachycardia with a mild tachypnea, and saturation was 80% on Zoom here and showing significant hypoxia. And on examination, JBP is normal, and have auscultation that indicates some pulmonary congestion. Cardiac examination shows only like S3 gallop was present, and which is most often associated with a heart failure, and there is a moderate peripheral edema also. And on investigation wise, that is this natriuretic peptide, it is around 864, which is high, and ECG shows a tachycardia. And when you do the chest X-ray, it's a cardiomegaly. So from this history, any like a postpartum moment with a acute chest like cardiac condition, somebody comes. So I think like what will be the most probable diagnosis? So most fast we should diagnose it as a postpartum cardiomyopathy. It can be also pulmonary embolism or congestive cardiac failure or any other cause also. But if you see the patient doesn't have any other symptoms and presenting with all its symptoms, and if you come with the investigation and with the clinical features together, it can be a postpartum cardiomyopathy. So it's a big picture. I think all of us might have seen in our career, like obstetric career, this postpartum cardiomyopathy. So today you are going to discuss like how to identify, treat, and prevent it. So it's a rare cause of cardiomyopathy, which most of us know it occurs in the late age, like in the towards the late trimester of the pregnancy or in the early postpartum period. And it has a lot of different varieties of definition. If you see in the first definition in the 2000, as per the National Heart, Lung and the Blood Institutes, like there should be minimum 4 criteria to define it as a PPCM, that is cardiac failure when it occurs towards the last trimester of the pregnancy or within the 5 months, not necessarily exactly 5 months actually. And there won't be any identifiable any cardiac cause. There is no other etiology, and absence of any structural cardiac disease before the last month of pregnancy. And when you do a echo shows like left ventricular ejection less than 45 and the fractional shortening less than 30%, and the left ventricular end diastolic dimension which exceeds more than 2.7 centimeter. So any of the 4 criteria, like this 4 criteria, once it's established, you can diagnose it as a PPCA. And as for the European Society of Cardiology, so that means almost same criteria, development of the heart failure towards the end of the pregnancy or in the postpartum. And there is no any absence of any identifiable cause of heart failure. And once you do the echo shows the left ventricular ejection fraction of around less than 45%. And based on the timing of onset, it can be early PPCM or it can be late. Once it occurs within the first, means in the antepartum period, that is called the early PPCM. And once it occurs in the postpartum, it is between 6 to 12 months after the delivery.
So how it like coming to the epidemiology, like it is like the incidence of PPCM actually it is very geographically all over the world. But you will see they are more common in the Asian and the African countries. Indirectly, it indicates they have a possibly like some factors of the socioeconomic factors and also the genetic contribution. And nowadays, maybe the incidence has increased maybe because of the awareness of the heart disease during pregnancy and also due to the neurodiagnostic techniques. I think previously routinely we don't do a like ECG and echo routinely in the antepartum period. But nowadays, even Tamil Nadu government has imposed like all patients whenever they go for a second trimester, particularly for an anomaly scan, that time each and every patient is undergoing an ECG and echo. Because we are nowadays after doing that getting lot of patients with these cardiac symptoms, so that has become a now routine wherever like patient is affordable either in the government setup or in the private setup. Better to go for one ECG and echo. So because of this awareness, the incidence has also increased last few years. And some studies have shown like around 20% of the cases that occurs in the last trimester of pregnancy, but majority occurs in the first month of the postpartum. And among the postpartum, mostly they occurs within the first week of the delivery. And what is this pathophysiology of this postpartum cardiomyopathy? We know there is no previous any cardiac conditions, but still patient develop. What is the cause? So it can be autoimmune. There can be some hemodynamic stress as happens in the pregnancy. All the cardiac load it increases, and also there can be oxidative stress which leads to the toxic prolactin fragments and can be a viral myocarditis. So if we see there are two hit hypothesis, that means the environmental factors and also the genetic factors. These two together, it can be affected and it give rise to this complex interaction of these environmental factors and the genetic factors, which includes the mutation of the cardiac genes like TTNC, TTNC1 and TTN and START3, and anti-angiogenic factors like SFLT1, which inhibits the VEGF, and this SFLT1 and VEGF, it is also involved in the pathogenesis of preeclampsia. So that is why we see in in our Indian setup. So most of the patients who are having any hypertensive disorder of the pregnancy, either preeclampsia or eclampsia, they develop more of PPCM as compared to the other patients. And also prolactin hormone, it is also involved, which is increased in the cathepsin and dipeptidase hormone, it is increased. So basically the pathophysiology, it is a combination of both the environmental and the genetic factor. So you will see here, like the first is the gene mutation, second is because it is antivascular or the hormonal effect. One is prolactin, one is the SFLT1. So this pathophysiology, because we know this is little complex pathophysiology, and because without any cardiac, pre-existing cardiac disease, still the patient is like the antenatal woman can have a cardiac failure related symptoms. So the pathophysiology is little complex. And the risk factor you can divide into some maybe probable risk factor, proposed risk factor, or emerging risk factor. So probable risk factor, that means it is like a high parity or elderly age and parity like grand multiparity like that, and multiple pregnancy or extreme of the reproductive age, and those patients who are using prolonged tocolytics. But nowadays, I don't think anybody are using prolonged tocolytis. Tocolytis is confined to only the time the steroid is acting. So only for 48 hours you give, you don't give. But this is one of the risk factor. And the proposed risk factors may be smoking. As I told, hypertension nowadays, it is becoming the emerging risk factor in a PPCM, malnutrition, anybody having a cocaine abuse or any type of substance abuse, and the African countries, and the low socioeconomic status. And the emerging risk factor as these three. One is genetics, preeclampsia, and the obesity. I think obesity, it is nowadays, it has become a more than the diabetes. Obesity has become a non-communicable disease like worldwide. It is not only in India, worldwide. So obesity, preeclampsia, and genetics, these are the emergency risk factor if we'll see for the patients. So we know it is a diagnostic challenge because there is no specific test to confirm the PPCM, and it always remains as a diagnosis of exclusion. That means if they exclude everything, suppose it doesn't fit to anything else, then you can diagnose it as a PPCM. So why we're worried? Because why it is a diagnostic challenge? Because most of the time the symptoms the PPCM has, it mimics the normal pregnancy symptoms like palpitations, abdominal pain, chest pain, orthopnea, cough and all. So even in a normal pregnancy also towards the like a third trimester, patient can have a shortness of breath, fatigue, pedal edema, little bit of tachycardia, everything will be there. So because of this significant overlap between the symptoms related to pregnancy, and so there is a diagnosis may be initially missed or it can be delayed. So we have to be very vigilant when you think of the patient. We should be aware of this PPCM so that you can think in that line if anybody is having these symptoms. And many a times like a PPCM or preeclampsia, even both the symptoms also sometimes it will overlap. Like in a preeclampsia also there can be edema and pedal edema can be there, pre-existing or new onset hypertension, proteinuria will be there, and there can be a left ventricular hypertrophy with a diastolic dysfunction. And similarly the PPCM, as I told in the initial slide, there can be a left ventricular ejection fraction delay less, and towards the end of the pregnancy patient can have all this hypoxic symptoms. So there can be this preeclampsia and PPCM also, it can overlap, and it is the most important cause of PPCM also, preeclampsia. So you will see this identifiable clinical features once you take the history with the symptoms, and with the when you auscultate, there will be some pulmonary rails due to the left-sided congestion, and there can be elevated jugular vein like because of right side congestion, and symptoms of congestion like dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and lower F means pedal edema. With all these clinical symptoms, we'll go for a diagnostic workup. So what is, suppose any patient comes with all symptoms and she is not a known case of heart disease, and in that case we should suspect with the symptoms there can be a suspected acute PPC. So there with the routine test like ECG and chest X-ray during pregnancy we don't do. But once patient is coming in this condition, you can with the abdominal seal, you can go for X-ray. So that can see but in now with all sort of newer investigations, X-ray I think it is not needed. But there can be, if you are doing, there can be chance of pulmonary edema with the inless cardiac celoty. And once you do the this natriuretic peptide, usually it is elevated. And in a normal pregnancy, it is not elevated. So when you do either a BNP and echocardiograph, echo is very important in the coming to the diagnosis. So if the value is abnormal values, if the value is normal and the ejection fraction is more than 45%, then it is unlikely to be acute PPCM. So you have to think these two are very important in the diagnosis of PPCM. If the values are abnormal and the LVF is less than or equal to 45%, then you can think of this PPCM. So that is why anybody coming with this kind of symptoms, the measurement of this natriuretic peptide and echo are recommended quickly or to rule out the diagnosis of PPCM. So we should have in our mind, patient comes with this without a pre-existing heart disease, at least this echo and one blood test should be done to rule out the PPCM. So coming to the differential diagnosis, as I told, patient can have a symptoms of this, it can be a just benign hyperventilation in pregnancy where you get a normal X-ray, normal echo, and there we don't need, patient doesn't need any treatment. It can be asthma also. It can be pulmonary embolism. It can be unmet embolism because they will again present with a sudden onset of dyspnea, and it can be a preeclampsia. And here this slide, this table, it shows how to differentiate all kind of this symptoms either it is a pulmonary embolism or amniotic fluid embolism or it is a PPCM. All of us were well aware of the symptoms and the investigations. So, but we have to think in mind of PPCM. And what are the circulating biomarkers? We do the clinical examination, we do minimum investigations like echo and like a natriuretic peptide, but there are some biomarkers which can diagnose the PPCM. So there can be a diagnostic marker or it is a prognostic biomarker or it can be both. So this prolactin and this BNP and this routinely, these things you can do in most of the hospitals, it is available. And then the prognosis biomarker, those whatever it is in the blue, relaxin 2, and these are all for the theoretical purpose, means routinely we don't do all these investigations. So mostly you do this BNP and the echo. So these are the circular biomarkers which can help in the diagnosis of the diagnosis and also the prognosis of the PPCM. So it can be vary from the minimal sign symptoms to the severe acute heart failure and the pulmonary edema. So it can be a mild where there is a subacute heart failure and hemodynamically patient will be stable. And in the moderate PPCM, there can be acute heart failure, but patient will be hemodynamically stable but respiratory insufficiency will be there. And in the severe PPCM, patient may go for a cardiogenic shock, both with the hemodynamic instability and the respiratory insufficiency. So PPCM, like we know, it is a therapeutic challenge. We are worried because we have to save both the mother and the baby. So how do you proceed with the management? Once patient is coming without any like risk factors suddenly developing a acute symptoms. So management considers means like always once you see this kind of patient, so patient has to be with the like coming to a intensive care unit with the cardiologist standby. And here you can just put the sodium restriction may be required and symptomatic pulmonary or the peripheral edema present. You can give the diuretics. If the patient is hemodynamics permit, you can give the beta blocker, and specifically we should avoid the SC inhibitor or the ARB blocker, which is routinely contraindicated in pregnancy. And you can start these drugs in the postpartum period. And digoxin also can be used. And if the like ejection fraction is less than 35%, and those who are on bromocriptine, I'll be coming there like which meant to start this bromocriptine. So we sometimes use this anticoagulation you can use. And cardioversion and the defibrillation may be used in the like emergency settings, but it is quite safe in the pregnancy. So you will see the guidelines. So according to this latest, this European guidelines in 2018. So it does, and the heart failure management and the PPCA management almost it is same, and it is that is no different treatment. But only thing is that you have to see some drugs, whatever it is contraindicated in pregnancy, that should not be given to the patient. So first, you acute heart failure and the cardiogenic shock has to be stabilized. Then after that, you can go for the chronic management. And here, if it is like a mild, this moderate and the severe PPCM, if patient in the normal ward and sees ambulatory in selected patients wherever it is possible, so you can start the oral heart failure drugs like digoxin and oral diuretics also in some cases if there is fluid overload, and consider the bromocriptine for 1 week because prolactin is the important hormone involved in this PPCM. And in intermediate care, so we can give IV diuretics and consider some vasodilator if BP is high. And you can give the oxygen therapy if without just a simple oxygen, not in like NIBP, and avoid the inotropes and the catecholamines. And bromocriptine has to be continued for 8 weeks if the ejection fraction is less than 25%. And once this patient is stable, you can start the oral this heart failure medicines. And if the patient is in ICU, then again diuretics, inotropes, if it is needed, you can give. And patient may go for the ventilation mode, invasive ventilation and mechanical circulatory support also if needed. And once the patient is stabilized, then bromocriptine has to be continued for 8 weeks. And other oral heart failure medication can be given once the patient is stabilized. So coming to this defibrillator, so when the left ventricular ejection fraction is less than 35%, so either you can use a wearable cardio butter defibrillator or it can be implantable. So because this left ventricular recovery is common in PPCM, so to decision to insert one, whether it is implantable in a patient who initially presents, that can be delayed because sometimes most of the 70 to 75% of patients that left ventricular recovery is very common. So that decision to take whether to put an implantable defibrillator or to put only the compressible, the usable, that you have to decide. So this wearable compressible cardiovascular defibrillator, it could be used as just a bridging therapy until the left ventricular ejection fraction is re-evaluated in the follow-up. And the ICD is based result for the patient with PPCM without LV recovery after 6 months. Because mostly in 70% of patients, this left ventricular like function, it recovers or comes back gradually within a period of 6 months. And the coming to the obstetric management, so pregnancy specific considerations should be second. So means we should avoid taking over diuresis because already there is a pulmonary edema, for that you have to give. But to maintain the perfusion of the placenta, over diuresis should be avoided, and close monitoring throughout the pregnancy, like not only during pregnancy and also 6 months postpartum with echo, and wherever either that protocol I'll come when to do the echo, everything in the PPCM. And then that means each trimester you have to do immediately after delivery and 4 weeks postpartum. So these things, because even if patient had a PPCM, post delivery you have to definitely monitor the patient for minimum 6 months. And the timing of delivery, that depends upon it's mostly delivery is planned based on the obstetric indication. If patient is stable, you can just continue the pregnancy if the obstetric indication indicates. If patient is unstable and it is in the extreme, there you need to deliver the patient because we need to manage the mother. Without baby, management will be much easier. And coming to the breastfeeding, but though there is some controversy regarding the breastfeeding, if the patient is in a very acute condition such as severe left PPCM, there we need to maybe breastfeeding should not be given during that time. Otherwise, in a mild or moderate cases, breastfeeding can be continued. And again, delivery, like whether to go for a vaginal delivery or a cesarean section, again, it is both. Like if patient is stabilized hemodynamically, urgent delivery, means urgent delivery is not needed. So whenever you are not, patient is hemodynamically unstable and we need to deliver the patient fast so that you will manage the mother properly to treat the PPCM, there maybe you can go for a cesarean section. Otherwise, there is no indication of cesarean section for only because of the PPCM. And if the patient is hemodynamically stable, otherwise vaginal delivery is preferred. And breastfeeding, as per the guidelines, because of the high metabolic demand of the lactation, so this preventing lactation may be considered in a patient who is having a severe heart failure in a PPCM. But in patients with those who are taking on bromocriptine, they may be considered to stop the lactation to enhance the recovery of the left ventricle. And bromocriptine treatment should be accompanied by the prophylactic anticoagulation. And this is a board scheme for the therapy of the patients with acute PPCM. And this is particularly regarding the board means B starts for the bromocriptine and then this oral heart failure drugs like either beta blocker, SC inhibitor after postpartum, after the delivery. Or patient can be then again she can anticoagulation when she's taking bromocriptine and any vasodilator and the diuretics. So altogether it's called a board scheme. So particularly this PPCM should consider mostly following the delivery once the patient is stabilized, then you can consider this board treatment. So coming to this bromocriptine, when to continue, how long you have to continue. So if the left ventricular ejection fraction is more than 25%, there is no cardiogenic shock, no ICU treatment, then you can continue for 7 days, 2.5 milligram once daily. But at least one prophylactic anticoagulation should be continued. If it is less, again, LVEF is less than 25 and there may or may not be right ventricular dysfunction or may or may not be cardiogenic shock, like either or ICU treatment, then again you have to, here you can continue for 2.5 milligram twice daily for 2 weeks, followed by again once daily for another 42 days or 3 weeks you can continue. But all the cases, whenever bromocriptine is there, at least prophylactic anticoagulation should be continued with the heparin. And ICU treatment, patient with the cardiogenic shock or with the invasive ventilator, there, once the patient is stabilized, so start with the bromocriptine 2.5 milligram twice daily. And again, you can titrate to 10 to 20 milligram daily, depending upon the serum prolactin levels, unless the successful suppression, it comes back to normal values. And again, you have to start with the prophylactic anticoagulation. So the bromocriptine and the anticoagulation both should go side by side whenever patient is having a PPCM, and based on the left ventricular function, the dose and the duration of the bromocriptine also varies. So what is the clinical outcome of this postpartum cardiomyopathy? As I told, mostly 70 to 75% of the patients, they comes back. That means the ejection fraction comes back to more than equal to 50% within 6 months of delivery. But some patients some race means black woman or left ventricular initially itself when it is less than 30% or the remodeling is more than equal to 6 centimeter, these patients are the poor predictor of the PPCM. That means the recovery will be very poor in this kind of patients. Otherwise, up to 70% of the women, they can improve the cardiac function can be improved within 6 months of the delivery. So the maternal mortality is vary from 2 to 50%. So risk factor means those patients who are class 3 or class 4 NIH classification, or the left ventricular ejection fraction is less than 25%, black race, multiparity, age more than 35 years, they have a more chance of mortality related to PPCM. And now once the PPCM has occurred, we have treated the patient either antepartum or the postpartum, and the patient becomes stable. The most important is the next step, like the subsequent pregnancy. And counseling, how do you need to do the counseling of such kind of patients? So the left ventricular ejection fraction, that is actually it is the strongest predictor of the outcome. So based on that, we should counsel the patient. If the ejection fraction is less than 50%, so 50% risk of acute heart failure is there with worsening disease and the increased mortality. And pregnancy is contraindicated without the recovery to the normal LVA. So we have to immediately, any woman like antenatal, like any woman who had PPCM, so without it is coming back to normal, you should not plan for the counsel the patients, you should not become pregnant immediately. And you will see here, like this is the classification. If the PPCM is more than equal to 50%, there is a risk of relapse of the subsequent pregnancy, but the risk of heart failure of the death is less than 10%, and usually they will have a good fetal outcome. So specific management, so pregnancy can continue, but the risk remains same. And bromocriptine we should give in the postpartum, and patients should be delivered in a tertiary care center where the cardiac care is can be given properly. And the general like maternal health factors like age less than 18, like the both extremes of the age that predict like a teenage pregnancy or the elderly pregnancy, poor maternal education, like low socioeconomic status, and the long distance antenatal care and the late presentation, these things also we have to take into account. And PPCM with the poor recovered LV function, that is less than 50%, they are high risk for the relapse, and the pregnancy, heart failure and the death risk is more than 10%. Again, risk of preterm delivery and risk of IUD, those conditions also are there if the left ventricular ejection fraction is less than 50% after recovery. And specific management, again, the physician should advise we should against the particularly if the ejection fraction is less than 30%, better to tell the patient to avoid the pregnancy, and we can start on this board therapy like bromocriptine, like oral drugs for the heart failure, anticoagulation, and the vasodilators and the diuretics. And general management, as I told, all these patients should be delivered in the tertiary care center where the cardiac care facilities is more. And for them, we have to do the routine echo in the good interval, we have to do that. So the recommended schedule screening for the echo for with the history of PPCM, that means pre-conceptionally, once the patient is recovered after 6 months, we do the pre-conceptionally one echo to know whether the LVF is more than 50% or the less than 50%. Based on that, you have to plan the patient, counsel the patient for the next pregnancy. And if at all it is a good LVA, then patient is going for the pregnancy. Again, each trimester you have to do. And first trimester, second and the third trimester, but not necessarily once you have done in first, second and third trimester. Even if patient based on the need, suppose in between patient coming with some symptoms, then you have to repeat it. And again, 1 month before delivery means just towards the end of the delivery, and postpartum, again you have to do it. So because we know the PPCM next pregnancy, it can recur based on the LVA, we have to plan for the next pregnancy. So contraception is very important. Orally, it will tell the patient may not understand anything, and they may come back with the pregnancy. So the right form of contraception is very important to again prevent the recurrence of the PPCM. So what are the contraceptive we can give? So we know this combined OC pill is absolutely contraindicated in these cases. Either you can give a progesterone only pill, or it is very safe with intrauterine device you can give. Means intrauterine anything. Either you can give a copper IUCD or you can give a any other intrauterine device you can give. But combined oral contraceptive pill is absolutely contraindicated here. So you will tell in a PPCM where is the gap, whether there is a knowledge gap or the research gap, because we don't know because without any symptoms when the woman present, everybody become panic. What is the cause of this disease? So the knowledge gaps in the PPCM research means mostly related to the pathogenesis, because the pathogenesis is multifactorial, and the symptoms, the diagnosis, because the diagnosis it mimics most of the time the routine symptoms of the pregnancy. So that's why sometimes the diagnosis become delayed or it become missed. And management, it required a multidisciplinary management with a tertiary care center with a good cardiac setup. So there are also some other like unanswered questions like the optimal treatment of the woman who was recovered from the LVN, and where like most of the cases they usually they make up like means 70 to 75% they make up the LVF within 6 months. So that is why treatment is recommended for at least 12 months after the recovery or both the left ventricular ejection fraction and the dimension. So we should follow up the patient not only even if the within 6 months it comes back to normal. So we have to count means do keep the patient on follow-up minimum for 12 months. And a period of time without medication and with recurrent echo, it is ideal for the confirming that the ejection fraction doesn't deteriorate before a decision of regarding a new pregnancy. So minimum always we should advise the patient to have a contraception minimum for 1 year. And in the meantime, patient should come for periodic checkup. You do her echo and check her LV function, and accordingly after that you can ask the patient to plan for the next pregnancy. So at the end, like what do you do when the doctor fails to, because as of nowadays, this litigations have become too much actually. So we had actually practical experience, one patient in our hospital, like post-cesarean, immediately she developed all these breathlessness, acute cardiac symptoms. She didn't, that was just a low risk case, means it was a previous LSCS taken for a, like she came with pain with a scar tenderness, so taken for emergency cesarean section. And patient was there in the ICU for almost 55 to I think 2 months. ICU then so slowly she is rebirth, and the patient husband is a lawyer. So he has created a lot of ruckus in the hospital. So always this because the diagnosis, the presentation, and the pathogenesis all are totally not. It is not very clear, and so that is why maybe we should like we should not land up in a such kind of litigations. So we have to be very careful, and we should think of this PPCM in our mind when the patient comes with this kind of symptoms. Then we can manage it properly. So take home message. So it is a maternal heart failure. It occurs either late pregnancy or the initial 5 months. So it is always a diagnosis of exclusion. So we have to see the other all the differential diagnosis. Then we will come to the diagnosis of PPCA. And most commonly nowadays it is associated with preeclampsia. And approximately 15% of the PPCA they are genetic variant. So genetic testing should be considered in most cases of PPCA. And management, as I told, it is routine with the heart failures. And with the breastfeeding, most of the standard medications are acceptable. But some newer drugs like this valsartan and sodium glucose contrast transporter 2 inhibitors, those things, these are under research whether those drugs can be given or not. And cardiologist will tell better on those things. And bromocriptine is a routine drug we give. And whenever you give the bromocriptine, and there is one also being actively investigated of this randomized trial on the bromocriptine in the cardiac recovery therapy. And due to the peripartum hypercoagulability, whenever you are giving bromocriptine, so anticoagulation is always recommended. And after a diagnosis, the temporarily wearable defibrillator is preferred as compared to the implantable defibrillator, and vaginal delivery is preferred when the patient is stable, and lactation is not contraindicated in the mild form. And counseling the patient for the subsequent pregnancy, it is very important, and that should be done by experienced team. And also we should, it is not only you can document in the case sheet for contraception, rather we should counsel the patient and you should follow up the patient. Patient should make use of contraception. Thank you so much for the kind listening.
A really very beautiful presentation given by Dr. Sunita Samal ma'am. And this was really very informative. And with increasing age of pregnancy in this era, plus inadequate lifestyle, this disease has been increasing. And particularly, I don't know what, correct me if I'm wrong, after COVID, this thing has increased to a bit more level. I don't know what is the reason, but I have seen 3 cases in last 3-4 years of cardiomyopathy, which we were not seeing that regularly. And you have really very adequately explained everything. And one thing what I would like to add is in all our prenatal visits, like we should schedule as the way we schedule the ultrasonographies, we should actually schedule a 2D echo for all the patients in last trimester of their pregnancy, so that we are prepared for the anything that happens wrong during the delivery period. Otherwise, it comes to the doctor altogether. My
Yes.
husband is an intensivist, and I make it sure that every patient, whoever we are dealing in the third trimester, get 2D code done in that third trimester. And believe me, we really come up with too many surprises in the echo during the last trimester. And if we get right diagnosis right in time, treatment becomes easier and more effective. And
Yeah.
last, one more thing, you talked about the medical legal cases. I would again like to extend one thing. The teamwork is the key, I mean, most important thing in this kind of situation, because if you have a cardiologist, a intensivist, and a complete team dealing with the situation, then the situation is more manageable. I mean, like the untowards thing still come, but they become more manageable if you have a team of doctors working on this kind of cases.
Yeah. Thank you. Because
Thank
that's
you
why
very much. It was a beautiful presentation. Beautiful.
we do a echo, and for all antenatal patients, we do echo for all patients.
No, that is very right, ma'am. I mean, like it used to be a costly investigation at one time, but what we have done is we have just slashed down the rate, because again, in our area, getting one more investigation for the patients with this kind of monetary problems is difficult. So what we have done is we just do a screening echo, and
Yeah.
with minimal amount of, so that
Yes.
patient doesn't have any problem doing it.
Yeah,
But we
screening of a
definitely
cancer.
get too many positive reports these days. Thank you very much. It was
Thank you.
beautiful presentation. Beautiful.
Thank you so much. Thank you, ma'am.
Thank you, Dr.
Thank you so much for the wonderful session, ma'am. Sunita Samal ma'am and Sunita Vadvani ma'am. Like I think all points were crisply covered. Thank you so much, ma'am. So moving on to the next session, where we have a panel discussion on heart disease complicating pregnancy. We have a moderator, Dr. Bhumika Gunasingh, who is assistant professor at OG Arne Medical College and Hospital, and her special area of interest is high risk obstetrics. Then we have our esteemed panelists. Yeah, next, please. We have panelist Dr. Swati, who is currently working as an assistant professor at SMMCH and Research Institute of Chennai. Next. Dr. Priya Kannappan, who is South Zone Coordinator of Quiz Committee, FOXY, and also the Consultant Obstetrician Gynecology at Mehta's Hospital at Chennai. We have Dr. Radhika Gauri, who is a Consultant Obstetrician and Gynecology at Tirunelveli. And Dr. Monica, who's currently Assistant Professor at Department of Obstetric and Gynecology, MMC Research and Research Institute. Dr. Rekha Ratnani, who's a professor and HOD at Department of Obstetric and Gynecology at Chhattisgarh from Bilai Society. Dr. Neha Sharaf from Ratlam Society. Dr. Dolly Mehra from Ratlam Society. Yeah. Over to you, Dr. Bhumika.
So at the outset, I'd like to thank Sampath Kumari ma'am for giving me and all our panelists the opportunity for conducting this wonderful panel on heart disease complicating pregnancy. So we'll start off with the first case. 26 years old, primi gravida, 24 weeks of gestation, residing in Tirunamalai, came to the OPD for routine antenatal checkup. She didn't have any specific complaints. It was a spontaneous conception. Pregnancy was confirmed by urine pregnancy test at 60 days of amenorrhea. NT scan was normal, no other significant history. And second trimester history, anomaly scan done and anomalies ruled out, iron and calcium taken. No nil significant medical and surgical history, and all other family history was also negative. On examination, she was afebrile, no pallor, no pedal edema. JVP was not elevated. Pulse rate was 90 beats per minute, and BP was 110 by 70 millimeter of mercury. So on auscultation, S1, S2 was heard, and a mid-diastolic rumbling murmur was at apex with pre-systolic accentuation was heard. RS, no normal vesicular breath sounds and no added sounds. Per abdomen, uterus was 24 weeks, relaxed. Fetal heart rate was 150 beats per minute and regular. So, what is the probable diagnosis based on the above mentioned case findings? Can Dr. Swati take this question, please? Hello? Am I audible? Can Dr. Swati or Dr. Priya?
Hello, yes, ma'am. Actually, we had mid-diastolic murmur, ma'am. So it could be a case of mitral stenosis, rheumatic heart disease.
So yes, we had a mid-diastolic murmur, which is significant of a mitral stenosis. So now that you've found this murmur on auscultation, would you like to ask any other history to this patient? She doesn't have any complaints. She just came for her routine visit, but you picked up a murmur. So do you want to ask any other questions to this patient?
Yes, ma'am. Any episodes of like dyspnea, chest discomfort, limitation of physical activity at present, or she is able to do her regular day-to-day activities on her own without any discomfort? Any history of like PND, orthopnea, syncope episodes? Anything happened as soon as the pregnancy is confirmed? Like that, all the histories to be asked, ma'am.
Yeah, since we've picked up this murmur and we've come to a diagnosis of mitral stenosis, we definitely have to ask if she's having a history of breathlessness. Even though she's symptomatic, she's not telling us any complaints. Maybe our history could probe some relevant history. So we have to ask history of orthopnea, history of paroxysmal nocturnal dyspnea, and very important, history of dyspnea on exertion. So, can Dr. Priya take this question? What is the NIHA classification or the New York Heart Association classification?
So usually you classify based on the symptoms which the patients are having. So whether either they are limitations, there are two things. One is symptoms at rest. Second is there any limitation for physical activity? So whenever there is no limitation at all, it is great. I mean, stage 1. If there is slight limitation is there, but however she's very comfortable at rest, so that is great too. And third is marked limitation. So any activity will have a little bit of breathlessness or difficulty, then we call it as grade 3. And if it is grade 4, we say that she'll be symptomatic at rest itself. So that it usually helps us to classify, and based on that it is also easy to prognosticate the patient, and you can also tell them what to expect, and also decide on whether OPD management or you need a inpatient care.
Yeah, thank you, Dr. Priya. You just summarized it very beautifully, because based on this NIHA classification only, we'll be deciding whether we can manage the pregnancy as OPD or whether she requires admission, or whether she can continue her pregnancy itself is based on this classification only. So based on this, we asked further history to the patient, and she's telling she's very comfortable at rest and she doesn't have any breathlessness. And so what class of NYHA does she fall under?
It's probably grade 1.
Yeah, she's definitely a class 1 of NYHA, because she's very comfortable at rest. She's not having any breathlessness. But this mitral stenosis was picked up incidentally on her routine antenatal checkup.
So this is a learning point for all junior colleagues. Like in first visit, you have to auscultate the patient, not at 24 weeks, because you missed the window of even at all you want to give an MPP, you cannot do it anyway. At 24, we don't have the rights.
Yeah. So definitely the first visit when the patient is coming, all of us have to put a step on the patient and auscultate to see if she's having any murmur, because definitely we can pick up, because if we find something abnormal, we can always refer to the specialist and get it sorted out. So what are the investigations would you like to do for this patient? Can Dr. Radhika take this question? Can Dr. Radhika take this question? Or can Dr. Monica take this question? What are the investigations you would like to do for this patient? Is Dr. Monica there? Can Dr. Rekha take this question? Dr. Priya, can you take this question, please? What are the investigations you would like to do for this patient?
So we cannot miss the routine things because you have to rule out hemoglobin, anemia in this patient, because you will add an extra risk for cardiac failure for her. So at 24 weeks, we'll always do a CBC, OGTT, OGCT and a urine routine for her. Along with that, echo is the only thing which is going to give me a diagnosis to clinch that whenever you have a a murmur, suspicion, you have to confirm. So echo. So 2D echo. I will not go with ECG in a asymptomatic women because it's not going to give me any additional information. So I will not do ECG. Echo I will definitely do.
So yeah, in Tamil Nadu, it has become a routine that all antenatal patients are subjected to an echo and an ECG as a screening, and it is part of the Tamil Nadu government guidelines also, because they do not want to miss any such occult lesion. So that is why all the women are subjected to echo. And like ma'am said, all investigations as per routine antenatal care, because she's 24 weeks, we'll have to do screening for GDM and we'll have to do CBC and urine routine as per any routine antenatal care. So the echo done shows mild mitral stenosis with a mitral valve area of 1.8 centimeter square, and the ECG was normal. So, what is the classification of mitral stenosis? Can Dr. Rekha take this question? Can Dr. Rekha take this question, or can Dr. Neha take this question? Dr. Neha? Dr. Dolly? Can Dr. Dolly take this question? Can Dr. Swati take this question, please?
Actually, mild, moderate, and severe stenosis is the gradings of mitral stenosis, ma'am. Usually, mitral valve is 4 to 6 meters square. If it is a mild thing, then it will be within the range of 1.5 to 4. If it falls 1.5 to 1, then it becomes a moderate, and less than 1 becomes a severe stenosis, ma'am.
So definitely, so it is very important for us to know the classification of mitral stenosis, because our management is going to differ based on the classification. So a mild stenosis will usually be asymptomatic, and it will be picked up only while we do a echo or by physical examination, while as a moderate or a severe stenosis will definitely, the patient is going to present with breathlessness. So based on the findings, definitely she is a case of mild mitral stenosis. So how often do you need to follow up this patient? She is falling under NYHA class 1. So how often will you need to follow up this patient? Can Dr. Monica take this question, please? Dr. Monica? Is Dr. Monica here? Dr. Rekha? Dr. Neha? Dr. Dolly? Can Dr. Swati take this question then? How often do you need to follow up this patient?
We can call her every 2 weeks, ma'am. She is now 24 weeks. We can call her until 30 weeks, every 2 weeks. And after that, weekly, we can follow up her till delivery, ma'am.
Yeah, definitely we can
And
call.
also, each visit, we should explain her the warning signs or any variations in the symptoms. Her dyspnea is getting worsened, like that. In each visit, we should ask her anything new symptom arises or any symptoms is getting worsened, ma'am.
So definitely we'll have to explain, once we've come to a diagnosis of mitral stenosis itself, we have to explain her the danger symptoms. If she's having breathlessness in rest, or if she's having breathlessness on exertion, or any other symptoms like that, she has to review back to the hospital at any point of time. And if it's NYHA class 1 or 2, we can follow up by every 3 weeks till 28 to 30 weeks. And after that, every 2 weeks till 36 weeks, and weekly thereafter. So this is only if it's class 1, because at any point of time, they can progress to class 3 or class 4. which might require admission or close follow-up or even termination of pregnancy. So, what are the complications we should expect in mitral stenosis in pregnancy? Can Dr. Priya take this question, please?
So related to pregnancy, most of the heart patients can be like, landing up with preterm labor. So that is the only thing which is for pregnancy. It may bear maybe a little bit of risk of FGRs for any heart disease because of your hypoxia. Other than that, pertaining to cardiac disease, they mostly go in for left ventricular failure, pulmonary edema. Sometimes, rarely they land up with arrhythmias, and sometimes they will have both left and right ventricle, leading on to that, and they'll have a complete cardiac failure as well. So pertaining to the heart and pertaining to the pregnancy is what we are looking at when we talk about complications.
Yeah, ma'am. So the fetal complications, like ma'am said, we'll have to look for FGR, and maternal complications, if they are going for pulmonary edema, cardiac failure, or also they have an increased risk of arrhythmias. So how are we going to manage this patient? How can Dr. Swati take this question, please? How are we going to manage this patient?
We can follow up her all the general examination, routine echo in every trimester, whether she is progressing or she is maintaining in the same grade. It should be a like a team multidisciplinary approach. Every visit she should consult the cardiologist as well, ma'am. And also the importance of the weekly visit nearing the term also we should explain her. If at all we have put her on any beta blockers, then it should be whether the BP is under control, we should check. And we can counsel for explain the modes of termination of the pregnancy and at what weeks, depending upon her symptomatic state.
Yeah. So it is a multidisciplinary approach. An obstetrician, a cardiologist, an intensivist, as well as a neonatologist should be looped in, because at any point of time, if her condition is going to worsen, if she is going to deteriorate and go into NIHA class 4, or if she requires any emergency procedure, if you require termination, you're going to give a preterm infant. So definitely a neonatologist also has to be looped in this management. So what is the role of surgery in mitral stenosis in pregnancy? Can Dr. Priya?
If your patient is symptomatic, then you will, especially when they'll have severe mitral stenosis, then you can think of surgery. Otherwise, usually for mild and moderate, it usually tolerate pregnancy well. So you may not need a surgery during pregnancy. If at all we have a safer time, it is always a second trimester, which is the safest period to go and do for any interventional procedure. Most of the time, they will try to go with only balloon valvotomy. They don't do the complete valvuloplasty during pregnancy. Once it is done, and then maybe they'll plan accordingly. And for mild and moderate cases, usually you don't need these surgeries.
Yeah, like ma'am said, for mild cases and moderate cases, usually they do not require an emergency procedure. But in case of severe MS, we will have to do an emergency procedure. So the European Society guidelines, as well as AHA and ACC, all advise the same only. And second trimester is the ideal time for surgery, that is 14 to 28 weeks. And if the mother is decompensating, then definitely we'll have to do the procedure as emergency. But preferably, if it is in the first trimester, she's class NIHA class 4, definitely we'll think about termination, more in terms of termination rather than continuation of pregnancy, to safeguard the mother. So all that should be kept in mind while taking the decision. And like we already discussed, it's a multidisciplinary approach. The cardiologist should also be looped in our decision making. So when are we?
One thing which I like to add is, whenever you have a NYHA class 4 patient, even in the first trimester, and you go at 6 weeks, even you try to terminate, the chance of losing the patient is more than 50%. So just because we do an MTP doesn't mean that she's going to have a good prognosis. The chances of losing the patient is more than 50% there. So we have seen patients dying at 6 weeks just with a severe MS. Even if you plan for MTP, you may lose the patient. So that we have to keep in mind. So she has to be in a cardiac ICU during the whole procedure. So we cannot have her in the labor room.
So when can we plan delivery for this patient with mild MS or moderate MS? When can we plan delivery for her? Can Dr. Swati take this question, please?
Usually, when there is no complications in this case, we can wait plan termination around 39 completed weeks, ma'am. Usually, we will wait for the spontaneous labor to initiate, and actually, vaginal delivery is better compared to C-section. So, induction is little generally to be avoided in case of heart disease patients. Better if she enters spontaneous labor.
Yeah, definitely. So if she is in NIHA class 3 or 4, we'll have to admit the patient, keep her under close monitoring in an ICU setup, and we have to reach up to the fetal maturity, and then we have to deliver them. But anytime, if case of any life-threatening complications, we have to terminate the pregnancy earlier on. So what is the preferred mode of delivery in such patients?
So a preferred mode is always vaginal delivery, as already mentioned. So we have like cesarean section only for obstetric indications. There are few of the heart disease where you don't want the patient to strain. For example, in aortic aneurysm or something where you don't want the aneurysm to break or rupture, or if you have something in your cerebral aneurysm. So those are the cases where we will do for directly cesarean section. And I mean the severe heart disease, we don't want the patient to strain at all. So that time, like if you go for an operative delivery, that is a cesarean section, you have the whole control in hand with you and the anesthetist. So that like severe heart disease, that is a group discussion where your team, your multidisciplinary approach, your cardiologist, everybody opines on what to be done. So most of the time we prefer a vaginal delivery. And I think the old saying, and even now we all agree with, cutting short of the second stage of labor. But previously we used to say the patient should not strain, so only forceps should be done. But I think now we agree with vacuum also. So either a vacuum or a outlet forceps to cut short the second stage of labor, and then you just proceed with the other things.
Yeah, definitely. Cesarean should be done only for obstetric indication, or in case of a very sick patient, we'll plan cesarean. So what is the preferred anesthesia of choice in case of cesarean? Can Dr. Swati take this question, please? Dr. Swati? Dr. Swati? Can Dr. Priya take this question, please?
Usually I think most of us, we go only with spinal for mild heart disease. So I don't think spinal is a contraindication, definitely, because nowadays we don't have that kind of big needles, or you don't give that medicines where they go in for sudden hypotension. So you just have to keep that in mind, because you cannot give a fluid bolus if at all your patient goes for hypotension. So I think, based on anesthesia, your anesthesia is the best one to take a and definitely, yes, a spinal with epidural bolus will definitely help you, because pain can push your patient to shock. So once you give an epidural there and the pain is avoided, a cardiac failure can, be avoided in those patients.
Yeah, so like ma'am said, spinal is preferred in this. If we have this the patient in question with NIHA class 1, then definitely a spinal is low spinal with top up they'll proceed with. But definitely if it's going to be a class 2 patient or more, they'll prefer to give an epidural anesthesia, because it will prevent that sudden hypotension. Because we do not want the patient to go for tachycardia, and we cannot overload the patient to compensate. So that is why epidural is better preferred. And it's always better if the patient goes to spontaneous labor. And if we have to induce, what is the method of induction that is preferred? Can Dr. Swati take this question, please? Is Dr. Swati here? Is Dr. Swati here?
I think her connectivity is not.
Yeah. I think it's just you and me now.
Yes, I think, yeah. So Foley's is always better. We all know that. And I think most of us will agree with us, because the Foley is the success rate is also much better. And the chance of infection rate is very, very less. So you need not to worry about that. And definitely amniotomy is individual choices, because many people we prefer not to do ARM in case you just wait for it. And most of the heart disease you need not worry at all, they will go with preterm labor and they will progress very fast, and kind of they will have a precipitate labor. So most of the time these patients may not need a prolonged induction or an augmentation, most of the time will not be needed at all.
Yeah, so even if augmentation, a low dose oxytocin is preferred rather than what the dose we usually give for our patients. 1 second. So the methods of induction to avoid in case of heart disease. So preferably it is better to avoid PGE2. Preferably it is better to avoid, because there are two school of thoughts. One say that PGE2 will increase the heart rate and it will cause adverse effects. But even PGE2 is quite safe because I've seen it. But they are telling it's better to avoid PGE2 and PGE1. So how are they going to manage this patient in labor?
So you will put them in a tertiary care. Yes, you have to have a facility. At least you should have a ICU and a HDU backup. Otherwise, you should not take a cardiology patient. Multidisciplinary. Keep your cardiologist informed that your patient is in labor. Definitely, your anesthetist should be kept in the loop there. And yes, the patient should be monitored with a multi-monitor, and the baby should be there with the CTG as well. Give a propped up position with the left lateral tilt so that you don't want your aortic cable compression as well happening. Just maintain an IV line. Don't give an IV fluid. It is better to maintain these patients on oral fluid rather than any IV fluid maintenance. So better avoid those things. And if a patient is in failure, then there is a role for diuretics and beta blockers. Otherwise, we don't routinely give for all patients in labor.
It depends completely on the symptoms. If they're already on beta blockers and diuretics, then it should continue.
Yes.
And preferably we'll offer epidural analgesia for all these patients to avoid tachycardia. And like you already covered, that we have to cut short the second stage of labor either by forceps or vacuum to avoid unnecessary pushing from the mother's side. And third stage of labor, all of us are trained to avoid methyl ergometrin, and we have to anticipate postpartum pulmonary edema due to autotransfusion. So the period immediately after delivery, 5 minutes immediately after delivery, we have to anticipate the patient going into failure, and we have to monitor her carefully for the next 3 days. So that is how management of cardiac pregnancy is in dictum. So how are we going to monitor this patient post-delivery? We've successfully delivered her by vacuum, and it was an uneventful delivery. So how are we going to monitor patient post-delivery?
The active management of third stage of labor should be planned. You have to give a IM oxytocin immediately after delivery. Sometimes these heart disease patients can bleed. PPH should be anticipated because only misoprostol is the other one which we can give. Tranexamic acid you can give, but we cannot give your methergin. PGF2 alpha, if it is not a severe disease, you can give. But in severe disease, you cannot even give prostaglandin there. So those are the things about PPH. And then when it comes, a patient that 1 hour should be monitored and then she should be shifted to HDU. At least we should keep her there for 48 hours at least, and then she should be there in the ward. So keep her there for 3 days. Then you can plan discharge. If it's a severe disease, then you go to ICU directly. And better not to give any IV fluid for a patient who's delivered vaginally. And diuretics, yes, if you suspect pulmonary edema, then definitely diuretics. If a patient is on beta blocker, you continue. If she's on cardiac failure, you give beta blockers. Otherwise, nothing special. Our ambulation depends upon the stage of NYHA. So if it's a severe disease, then you don't ask the patient to walk around. You keep her in the bed. Otherwise, early ambulation is better for them because we can prevent them from getting DVTs.
Yes, ma'am. So we have to keep her in HDU for monitoring, like ma'am said, and if she's in NYHA class 3 or 4, she might have to be in a CCU till her condition is stabilized, and she can come back to our HDU for observation. So what is the contraception of choice for this patient, ma'am?
Usually heart disease patient.
Yeah, Dr. Swati, you can take this question.
Yes, ma'am. Usually for heart disease patients, this levonorgestrel IUCDs are the safe options, ma'am. And if at all they are willing with the barrier contraception, well and good. But since the success rate is very less, we can advise her for LNG IUS, ma'am, rather than going for combined oral contraceptive pills. And also DMPA with like explaining them the warning signs. We can advise them progesterone only implant, DMPA injections, pills, progesterone only pills. We can give them options that as well, ma'am. But the
So-
safest is LNG IUS.
So the combined oral contraceptive pills and combined patch all come under WHO MEC category 3 and 4. So preferably it is good to offer 1 and 2. That is safe in pregnancy, benefits outweigh. One is contraception is safe in pregnancy, and category 2 is the benefits outweigh the risks. So it is better to advise these contraceptions to the patients. So among that, copper IUD, levonorgestrel IUD, and progesterone only pill and progesterone only implants are relatively safer. And DMPA injection should be used with caution. And definitely, we have to counsel the patient regarding spacing. And if she is probably class 3 or class 4, we have to advise her regarding the long term implications of the disease also. So, in case of valve replacement patients, so what are the guidelines for the use of anticoagulants in patients with mechanical valves? Can you take this question, Dr. Swati?
Yes, ma'am. Usually, when the patient is on warfarin, it is our this thing we can switch over to low molecular weight heparin, ma'am. But recent guidelines tells that the dose dependent side effect, if at all she is less than 5 milligram, with the close monitoring, we can due to the affordability issues also we can continue warfarin. But ideally, to switch to heparin till 13 weeks. After that, continue warfarin till 36. Then again switching over to heparin is ideal, ma'am. But if at all she is in warfarin high dose, for example, more than 5 milligram, then dose dependent side effects are common, ma'am. Like central and all.
So definitely. But if she has already crossed the first trimester with the warfarin, there's no point in us switching. We can continue warfarin and then switch back at 36 weeks alone. And like you said, if it's a lower dose, you will continue and then you will have to switch back only by 36 weeks, because before delivery, it's better if they are on unfractionated.
May I add, Dr. Bhumika, if that's okay? See, shifting over to heparin, yes, we all agree. Warfarin embryopathy is what we are worried about. But you will have your, like discussion with the cardiologist because warfarin is a more potent anticoagulant compared to your low molecular heparin. So if you are if you are having a disease where it is more prone for your thromboembolism or atrial fibrillation at risk, then your cardiologist says not to shift, then we continue even if we diagnose the first trimester. So it is not the decision which we take. If the risk is very high and they tell you to continue warfarin, we continue throughout with warfarin, and only during delivery we try to come down, because warfarin, it has a longer duration of action, so you cannot predict labor or you cannot manage during labor, and heparin is in our hand and our control, so that is why we do that.
Yeah, and warfarin also, it has the time period in which we are shifting from warfarin to low molecular weight heparin. Like ma'am said, there are increased risk of thrombosis. So that also has to be explained to the patient, and it should be an informed decision. She has to take the decision along with counseling with her cardiologist, like ma'am said. And when the patient is on low molecular weight heparin, strict anti-10A factor monitoring should be done. But the logistics of all this is quite expensive only, because warfarin is comparatively cheaper when compared to low molecular weight heparin. So all that has to be factored into, and a decision should be made. Because definitely a patient who is going to conceive with a mechanical valve, it's going to be an informed decision. Mostly it will not be an accident, and it will be a planned decision. Preconceptional counseling, everything would have gone through. So hopefully the patient also will be prepared for what has to come. So when will we stop anticoagulants before the delivery?
Yeah, if a patient is at high risk for thrombosis, then you cannot stop it very prior, because the risk of bleeding is going to be high. So that time what we usually do is we give IV unfractionated heparin, because it doesn't work in the other routes, and then that just needs 6 hours of stopping, and your low molecular weight 12 hours is good enough for you to go for delivery if it's in a high risk case. And especially when your patient is on therapeutic dose of low molecular weight heparin, it means she is at a high risk of getting a thrombosis. So those patients, we just give a 12 hours window. But if it is a low risk patient where that thrombosis risk is not that high, then you give a 24 hours window. So it depends upon your patient again. And so again, restarting of your heparin depending on the risk of the patient. If she's a high risk patient, you start early. If the patient's risk of thrombosis is not that high, then you can start it after 24 hours. So that is how we decide on the patient.
So, so for which patients will we be giving infective endocarditis prophylaxis? Do we have to give for this particular patient with a mild mitral stenosis when she goes into labor, or if she goes into cesarean? Do we have to give an infective endocarditis prophylaxis for this patient?
Actually, it is not recommended for routine prophylaxis is not recommended, ma'am. It can be recommended when there is a prosthetic cardiac valve or any past history of bacterial endocarditis or any like unrepaired cyanotic heart disease. In such cases, we can give her prophylactic antibiotics. For this case, as of now, it is
definitely
not
this patient
recommended.
will not
That is what
require.
our guideline says. But I think most of the obstetrician will give
Yes, ma'am.
antibiotic for a heart disease patient who's delivering.
Yes,
For
ma'am.
normal, other episiotomy only people give antibiotic. So I think for heart disease, definitely something you're going to give.
Yeah, ma'am.
That's
Definitely, we are going to give. If she comes with the minimal lesion itself, we are going to give. But as per the AHA guidelines, they tell it doesn't require, and only if they are high risk. That is, if they have prosthetic heart valves, previous history of infective endocarditis, previous history of thromboembolism, so unrepaired cyanotic heart disease, and all that. Only they require infective endocarditis prophylaxis. And the antibiotic of choice will be amoxicillin 2 gram orally 30 to 60 minutes before procedure, or we can give ampicillin 2 gram IV or injection ceftriaxone 1 gram IV. In case they are allergic to penicillin, we can give them clindamycin 600 milligram per oral or IV, azithromycin 500 milligram per oral, or clarithromycin 500 milligram per oral. So these are the antibiotics of choice. But because anyway, like ma'am said, even for a normal patient who's undergoing vaginal delivery, we cover them with antibiotics. So definitely we are not going to deny our cardiac patients from infective endocarditis prophylaxis. So now moving on to our next case scenario. Primary gravida, 28 weeks. She came with a screening echo of a secondum ASD 1.8 centimeter with mild RA-RB dilatation and normal pulmonary pressure, and she is asymptomatic. So what is the modified WHO classification of heart disease in pregnancy? Can Dr. Swati take this question, please? Dr. Swati?
yes, ma'am.
So basically, WHO classification of heart disease is for risk stratification only. Like we have many other classifications like CARPREC. WHO is also for risk stratification. Class 1 does not have. Yeah.
Class 1, there is no risk is nil, ma'am. Class 2, there is small increase in risk, like that unoperated ASD, minimal arrhythmias, that and all falls in class 2. Class 3, that if at all valve replacement is done and there is any mild left ventricular impairment, such cases falls under WHO class 3, ma'am. Class 4, that pulmonary arterial hypertension, NIHA 3 and 4, if at all the LVF is less than 30%, then such cases falls under WHO class 4, ma'am.
So it is for risk stratification, and we can use other classifications like CARPREC also. And what are the fetal risks associated with ASD in pregnancy? Can Dr. Priya take this question, please?
Yes. See, actually, with any heart disease patient, your risk of congenital anomaly doubles. So normally, for any patient having a risk of congenital anomaly is 3%. So whenever they have a congenital heart disease, then it can be like double, that is 6%. So it is not that high. We should scare the patient. So it is still like 5 or 6% is still agreeable. And now that we offer fetal echo for all the patient, so I think she will also fall in the same thing, and we'll tell them to go for a fetal echo by a proper, person who can just pick up this defect.
So this patient is definitely going to fall under class 1 because it's a small ASD and the risk is very less only for this particular patient because it is an uncomplicated ASD. So how are we going to manage this patient? A patient who's falling under WHO class 1 and NYHA class 1. She's not having any breathlessness. She's asymptomatic, low risk. So how are we going to manage this patient? So can Dr. Swati take this question, please?
We can manage her like routine cardiac cases as we advise, like 3 to 4 weeks follow up till she's 30 weeks. Then after weekly follow up, ma'am. And all echo could be done in every trimester to assess the LVF.
Yeah, so she'll be managed mostly like any other antenatal patient because it is a low risk cardiac lesion and she will not require any surgery during pregnancy, and elective surgery is not done during pregnancy, and only if she is very symptomatic, because definitely if she's come so far without any symptoms, definitely it's highly unlikely she's going to develop symptoms further on. So only in case of a large ASD, we'll have to plan a closure postpartum. So now moving on to what are the cardiac conditions in which the pregnancy is contraindicated.
So these are your WHO's class 4 conditions where the mortality is almost like 50%. So ideally, we tell them not to conceive, and if at all you pick them in the early trimester, we ask for termination for these pregnancies. So either it is a primary pulmonary hypertension, or is it secondary due to a Eisenmenger syndrome, or as we had a detailed discussion about peripartum cardiomyopathy with your non-recovering heart when the ejection fraction is still less than 30%. Or due to any other reason. We have even dilated cardiomyopathies, diabetic cardiomyopathies. So anyone who's having a LV dysfunction with the ejection fraction less than 30%, or if it is like already NYHA class 3, 4, even like the early trimester itself, and critical obstructive lesions of the aortic stenosis, pulmonary stenosis, or Marfan's with aortic root dilatation of more than 4.5 or 5 centimeters.
So definitely all these, pregnancy is contraindicated and we have to counsel them regarding the risk-benefit ratio and preferably to go for termination. But like ma'am highlighted in the beginning of this talk itself, even while going for termination, there's a risk. So counseling is very important and it should be an informed decision. Informed consent should be obtained and it should always be done only in a tertiary care center. And definitely if she's going to be class 3, class 4 in heart failure, she'll be in a CCU and obstetrician will have to go manage the patient there. So thank you very much to my panelists, Dr. Swati and Dr. Priya Kanappan ma'am, for the engaging panel discussion we had. So the take-home message of this panel discussion is we have to do early risk stratification, and based on that, they should be kept under close follow-up. And definitely we have to approach with a multidisciplinary approach. And during labor, we have to prevent cardiac overload and tachycardia. That is, good pain management is very essential. And IEC prophylaxis for high-risk lesions. And in case of mechanical valve, the anticoagulant should be appropriately managed because it is very, very important. And fetal echo in patients who have congenital heart disease and appropriate labor management is very, very important. So thank you very much.
Thank you, Bhumika. That was such a wonderful panel discussion. And thank you to the whole team for the opportunity. Thank you, Madhu. Thank you.
Thank you so much, ma'am. Thank you so much, Priya, ma'am. Thank you, Bhumika, for such a vibrant panel discussion. We really enjoyed it. So coming to the end of the session, I would first and foremost, I would like to thank Sampath Kumari ma'am for bringing us this wonderful webinar series, and I would like to thank the president and secretaries of Bidar Society, Dr. Uma Deshmukh and Dr. Savita, Bilaspur Society, Dr. Binha Chaudhary and Dr. Varsha, Bilai Society, Dr. Archana and Dr. Anjana, Narmadapuram Society, Dr. Ravindra and Dr. Sheetal, Ratlam Society, Dr. Sunita and Dr. Aditi, Mandya Society, Dr. Manohar and Dr. Shweta for the involvement in this webinar series. And I would like to thank our speaker, Dr. Sunita Samal ma'am, and our moderator, Dr. Bhumika Gunasingh, and our panelists, Dr. Priya Kanapan and Dr. Swati. And I would also like to thank Sahiti from Shield and Shri Priya and Chitrakala for the technical support, and all our delegates who joined today. Thank you so much, one and all. Thank you.
Thank you. Thanks a lot. Leaving.